Hi, everyone. Welcome to today's Journal Club. We're really excited to have Rylee here. So presenting her findings from her deep dive into our article today is future Dr. Rylee Ricks, who is in her final year at Roseman University of Health Sciences. Rylee brings an impressive background in both hospital and community pharmacy experience, and she has deep clinical interests in ambulatory care, emergency medicine, particularly also in both of those settings in the treatment and support of patients with substance use disorders. She has conducted extensive research on harm reduction strategies and the pharmacist's role in supporting recovery. And she also has been really actively involved in advocacy and outreach efforts in her community. I did also want to say Rylee is known for her thoughtful clinical analyses and strong skills in patient educational initiatives. And I'm really excited for her to lead us through today's Journal Club discussion. Rylee, I'll hand it over to you.
Awesome. Thank you so much. So like you said, my name is Rylee. I am a pharmacy student at Roseman University, class of 2026. Today, I'm going to be doing a Journal Club presentation. The study or article that I chose is called Adaptation of Tele-Harm Reduction Intervention to Promote Initiation and Retention in Buprenorphine Treatment Among People Who Inject Drugs, a retrospective cohort study found from Annal Medicine. The funding for this study comes from National Institutes of Health, the Florida Department of Children and Families State Opioid Response Grant, the Shipley Foundation, and the Foundation for Opioid Response Efforts, otherwise known as FORT. So some background for this study. So buprenorphine is an underutilized medication used to help reduce opioid use and overdose mortality, especially among people who inject drugs. The traditional care models that are currently in place have a lot of barriers for patients to get care, such as in-person requirements, stigma, insurance, and access to medical professionals, meaning providers and pharmacies. Tele-Harm Reduction, otherwise going to be referred to as THR throughout this presentation, is a peer-supported telehealth model that was used to help people who inject drugs start treatment, such as buprenorphine, through the use of syringe service programs. This helps to reduce barriers by offering care remotely in familiar and low stigma setting during the COVID-19 policy shifts. So going into the methods of this study, the objective of the study was to evaluate the adapted tele-harm reduction intervention, a peer-driven telehealth enhanced strategy on buprenorphine initiation and 3-month retention among people who inject drugs. And you'll see that abbreviation, the PWID, throughout this presentation as well. Looking at the study design, multi-component telehealth-based peer-driven retrospective cohort study located in the IDEA Miami Syringe Services Program, or SSP, in Florida. This study was conducted between February 1st, 2021 and May 30th, 2022. Looking into inclusion criteria, so people who inject drugs were included in the study if they were enrolled at the Bright Clinic at IDEA Miami SSP. If they received care between February 1st, 2021 and May 30th, 2022, they were included. If they had at least one buprenorphine prescription that was written and filled, this was verified using Florida's PDMP, or Prescription Drug Monitoring Program. And then if they received care either via telehealth or in person through Tele-Harm Reduction Program. Moving to exclusion criteria. So people who were not prescribed buprenorphine were not included in this study. If a prescription for buprenorphine was not picked up from the pharmacy, so it wasn't confirmed at initiation, and the MOUD is medications for opioid use disorder, or if they had missing or incomplete data in the retrospective chart review or the PDMP. Looking at endpoints, the primary endpoint of this study was defined as 3-month buprenorphine retention. Statistical analysis, I'm just going to go over it briefly to give everybody kind of an understanding, and then we'll go back through and dive deeper once you kind of have the big picture. So looking at this, it was retrospective observational data was used in this study to assess 3-month buprenorphine retention predictors in people who inject drugs. The difference in 3-month retention between THR and non-THR participants was statistically significant. P-value is 0.05, indicating meaningful benefit with the intervention. So there were a couple different analyses that were performed in this study that were mentioned. So there was a bivariate analysis that was completed with p-values less than 0.15. There's a chi-squared or Fisher's exact test that was used for categorical variables. There was a multivariable logistic regression model that controlled for age, biological sex, and race or ethnicity. Alpha was set at 0.05, and all analyses were conducted using SAS software version 9.4. So to kind of do a summary of the outcomes, results of this study, so the retention rate overall was 58.7%. So retention with telehealth was 75%, and without telehealth, it was 26.3%. So you can see the big difference there. The calculated absolute risk reduction was 48.7%, and then calculated the number needed to treat being 2 patients. So just doing the author's conclusions from what they got from this study, so they can successfully adapt SSPs to deliver low barrier, life-saving buprenorphine treatment in the way that is peer-driven, telehealth enabled, and destigmatizing for people who inject drugs. Tele-Harm Reduction was effective despite potential barriers like lack of ID, lack of insurance, unstable housing, stigma, marginalized populations, and pharmacy access. Using telehealth was associated with an increase in 3-month buprenorphine retention. Escalating doses of buprenorphine after a baseline visit was also associated with an increased 3 months retention. So now we're just going to kind of go back and dive deeper before we look at strengths and limitations of this study. So the big things that, just to kind of pull us back in, so the population that we're looking at are people who inject drugs. The intervention that we're looking at is Tele-Harm Reduction program. Comparator for this study was traditional and non-telehealth models. The outcome being buprenorphine initiation and 3 months retention. The time that they were looking at was 3 months. And then the study type is a retrospective cohort study. So when we look at the authors, Edward Suarez, Tyler Bartholomew, and Marina Pleasance, they're all associated with the Miami Miller School of Medicine in Florida. So there's not really any informatics backgrounds, but they all are licensed psychologists or PhD MD students that were involved in this study. And this journal was published in the Annals of Medicine and has a 5-year impact factor of 4.9. Jumping back down to the design section of this, so I talked about it being multi-component, meaning there are several coordinated elements such as telehealth visits, peer support, on-site medication storage, outreach medication delivery, and flexible follow-up. The telehealth-based part of that, meaning physician evaluations and follow-ups are frequently conducted using HIPAA-compliant video conferencing, especially when initiating the buprenorphine for those participants. Peer-driven, so peers with lived experience play a central role in facilitating access to care, helping deliver medications, conducting follow-ups, and providing ongoing support. And then it being a retrospective cohort study, the researchers viewed existing clinical and pharmacy data from February 21 to May 2022 to evaluate outcomes in a defined group. And the same thing is looking at data capture and documentation integrity. Some data, such as lab values, prescription dates from the PDMP, things like that, may have not been entered into a structured field using an EHR, though it's not explicitly stated in the article. But other information such as substance use, housing status, telehealth visits were most likely abstracted from free text from clinical notes or intake forms. EHR was utilized to obtain data from physician notes, psychologist notes, and lab values, and other sociodemographic data and telehealth services were from clinical notes, the Bright Clinic enrollment forms, and the IDEA SSP administrative database. Diving deeper into the inclusion criteria, some of it is also kind of inferred. The Bright program is the buprenorphine initiation and treatment experience clinic that is in Miami. So they have this thing called the IDEA Exchange. Essentially what this is they provide prevention resources via their main center, and they have mobile units that they also utilize. So they provide things like safe injection packs with like cotton, cooker's ties, sterile water, all the things that you would need to be safe while injecting drugs. They also provide naloxone packs, harm reduction packs with things like Band-Aids, antibiotics, and sanitizers. They also do HIV and hepatitis C testing, and they help link patients to rehabilitation and treatment. Looking at exclusion criteria, that point about if a prescription for buprenorphine was not picked up from the pharmacy, like it's not confirmed, could lead to missing information. Endpoints, they defined the 3-month buprenorphine retention as 3 consecutive months of picking up buprenorphine from the pharmacy using the prescription drug monitoring program for the state of Florida. Getting into the statistical analysis, we'll break it down a little bit more. So the bivariate analysis that was completed, so it was used to determine if there's a relationship between 2 variables and to determine how strong and what direction the relationship is going. And the increase in retention showed to be statistically significant. The chi-squared or Fisher exact tests were used in comparing retained versus not retained participants in the study. And the multivariable logistic regression model was used to show association between predictors and retention that I'll talk about in just a minute. As far as like the participants and their makeup in the study, kind of break that down a little bit. So 75.9% of participants were male, 78.7% were uninsured, 49.5% were non-Hispanic whites, 35.8% were Hispanic, 14.7% were Black, 70.4% were unstably housed or reported to have rough sleeping, and the median age for the study was 38 years old. There's a lot of different biases that I could think of that could be contained in this study, so I'll just go through ones that I thought of. I did not think that there was bias towards patients with tools to do telehealth due to provision of tools. If we refer to the study on page 735 in the top left of the thing, it talks about component 1. It says people who inject drugs were connected to same-day visits with medical provider and psychologist via an on-site peer specialist through telehealth. Patients didn't have to figure out where else to go or how to schedule an appointment. If they were interested, they could be connected that day. So that's really unique and really cool that they can, if they wanted the help, then they could get it right then and there. Selection bias, I think, could be a factor in this study. Only participants who accessed the syringe service program and were prescribed buprenorphine were included. So this may exclude higher risk individuals who dropped out early or never engaged in care, which could possibly overestimate the retention. People with more stability or motivation also may have been more likely to remain engaged. I also think that measurement bias or informational bias could have played a part in this study. Data was extracted from retrospective EHR review and provider notes, so much of which was unstructured and open to interpretation. And key variables like substance use, housing status were based on self-reporting or clinician interpretation, which increased the risk of misclassification. As far as confounding bias, even though the authors controlled for variables like age, sex, housing, stimulant use in their regression model, there were things like unmeasured confounders that could have affected the study, such as social support, mental health severity, prior medication history for opioid use disorder. Things like that could still influence the retention outcomes. So they did account for insurance status at enrollment, housing status at enrollment, the escalating dose of buprenorphine after enrollment, and then baseline stimulant use. But reminder that that was self-reported since many drug screens and urine analysis were not collected or required. Recall bias might also take place in the study. Self-reported substance use can be under or over-reported, especially without consistent testing. As far as attrition bias, retention was defined by pharmacy pickup, but it's unclear if patients actually took the medication. Some may have stopped using, but still picked up the refills or vice versa. Observer bias, manual data abstraction from free text notes may introduce subjectivity, especially in classifying variables like housing status or engagement level. And then the last one I'll talk about is external validity. The setting was a single urban syringe service program in Miami that was integrated with an academic institution, which may not reflect rural or non-academic harm reduction sites. So taking it to the results and the outcomes that way, like I stated before, retention rate overall was 58.7%. So that's 64 of 109 participants that benefited from it. 54 of 72 were retained with the telehealth, and 18 of 72 without telehealth. Defining the number needed to treat, only 2 patients need to receive at least 1 telehealth visit to retain 1 additional patient on buprenorphine at 3 months. So the predictors of this study offer practical insight. Retention is more likely in patients who had a telehealth visit or experienced a buprenorphine dose increase, likely reflecting early engagement and individualized care. In contrast, base stimulant use predicted lower retention, pointing to the need for additional support in the higher risk patients. For strengths of this study, peer facilitated services and technology. So those were things like medication delivery, connections to housing, that kind of thing, from people who have actually gone through it and could relate to those participants more. So this may reduce documentation burden and promote real-time feedback loops if it's connected to the right digital platforms. For the measure of retention and the limitations, it wasn't measured by actual ingestion or adherence, but by medication pickup and non-adherence. So my conclusion of this study, I think the study highlights an innovative low barrier approach using telehealth and peer support to improve buprenorphine retention among people who inject drugs. Despite its retrospective design, the results suggest that flexible community-based care can reduce barriers such as stigma, housing instability, and lack of insurance or ID. As a student pharmacist, this reinforces the importance of advancing harm reduction strategies and using technology to expand access. With expanding pharmacist roles, including collaborative practice agreements, pharmacists are well positioned to bridge treatment gaps in underserved populations. As pharmacists, especially those involved in informatics, our impact will grow when we ensure technology is used to inform, empower, and elevate clinical care, not just deliver it. So some main takeaways that I want you to have from this, I'm going to go through 3 of them. So telehealth combined with peer support leads to improved medication use for opioid disorder retention. So peer facilitated telehealth visits were strongly associated with a higher 3-month retention in buprenorphine treatment among people who inject drugs. Pharmacists in ambulatory and outreach settings can integrate into telehealth teams to provide follow-up, adherence support, or dose optimization remotely. The next thing is flexible dosing and person-centered care mattered. Dose escalation was significantly associated with improved retention. Rigid treatment protocols may underestimate retention. Shared decision-making and individualized therapy are keys to success. As clinical pharmacists, we can help tailor dosing strategies and support flexible prescribing, especially in fentanyl prevalent populations. And the last thing is informaticists must design for real-world data realities. Much of the data came from free text fields and required manual chart review, which limits scalability and quality monitoring. This proves the need for structured data capture, like the use of checkboxes for substance use, housing, telehealth encounters, etc., interoperability with the prescription drug monitoring programs, and dashboards to track medications for opioid use disorder outcomes in real time. Pharmacists can lead to EHR customization to support low barrier care workflows and enable quality metrics for medication use disorder programs. So now that we've kind of gone through it all, I have some questions for everyone else whenever you're ready. So how does technology-enabled care challenge or reinforce the pharmacist's traditional role in patient care?
Ooh, that's a good question. So, how do we have technology help reinforce how pharmacy is traditionally done and how that direct patient care occurs?
Mm-hmm.
Well, I think this article definitely is an interesting piece of that, of, can you have some predictive pieces of the puzzle or supportive pieces of the puzzle, especially for a population that might have a lot of loss to follow up. I mean, we see a lot of non-100% here, right? And in a lot of those interventions, and that's understanding the deep level of care that they provided. And so for me, it is interesting to look at, though, how high the numbers are, though, compared to studies that might not have as much support baked in. So what that tells me is if pharmacists were able to support more than just saying, hey, you can have like a visit with me or a telepharmacy visit with me or something like that, if we were able to get creative and have good like digital breadcrumbs of how we can help patients use those services, and maybe connect with them physically as well. Like you'd say, hey, can I help you learn how to use these services? Or, how can I help partner with you and advocate for you to get that support? I think versus it feeling unknown and unfamiliar to a patient, I think that would be incredible. I like that perspective. I would throw that question right back at you, Rylee. What are you thinking there? That's a great question.
Yeah. So I think that we as pharmacists can provide clinical services, whether it's counseling, adherence monitoring, things like that, through telehealth, because that's become such a big part of our world now. So, and that can help reach patients in programs like that, like the syringe service programs. It can help in rural areas, or if we're utilizing mobile units like they did in Florida, that can remove any of the geographic limitations that patients might experience with access to care. And in technology-enabled decentralized care models, pharmacists are essential for coordinating therapy, ensuring medication access, and educating both patients and providers. And technology doesn't replace the pharmacist, it simply just redefines where and how we care for our patients. I do have another question that I can throw at you.
Go for it. I like it.
How can we ensure digital equity for patients with limited access to smartphones, internet, or private spaces for telehealth visits?
What a good question. Digital equity is a big deal. Just a couple comments here, because like when I think about, I have some care experience for patients on the south side of Chicago, and you met people that didn't really know what brushing their teeth was. And I remember recognizing, wow, there's quite a bit we do take for granted as far as what's a patient's baseline knowledge of things. And so what is their access to the internet, to phone care, to a data plan, to a phone carrier plan? I think those are all really important pieces of the puzzle of, could organizations have, like you hinted at, like, is there a solution where that could be an organizational supported access point of, oh, here's our little telehealth hub that has little private rooms that may be in it, or with like iPads that are available, so that way the patient has that private space. I think that's a really good point, and why we potentially see a lot of counseling not occur in the pharmacy, because it feels like a very public place to discuss very private things. And I do feel like that could be a driver also in patients maybe not accessing a lot of pharmacy expertise, is that privacy piece as well. So in the digital space, that can absolutely apply also. But gosh, Quincy, do you have any thoughts there as well? So I think the question was, how can we start to make sure we're accounting for digital equity for patients, especially if we know there might be a limitation to access technology or internet, or even the private spaces for that care?
Yeah, I think like what you were saying, Megan. I mean, I think a huge part of it is like understanding, like when we have studies like this, we can see what an impact it can have in people that might not have had access before, or had things that were causing them to have issues getting the care that they needed, and the follow-up that they needed, and the treatment that they needed, and seeing, okay, this worked. We had substantially more people that were able to stay enrolled at 3 months. And I think once more and more of that information is like studied and understood, I think it just helps that you could eventually have something like you said, Megan, that it's a place that, hey, we have iPads that are here that you can talk to a pharmacist. So it really makes me think of people in rural locations too, just because sometimes there's not a pharmacy there. Sometimes they don't have access to someone to talk to. Sometimes they don't have access to very thorough or complete care. But if we knew what works and what doesn't in regards to like digital health and digital access, and what works to get them the most complete care. I think it would help to know what we would need to do to move forward and maybe make certain changes in locations and implement certain use of devices and so on and so forth. I think just as we understand and study more and have more backing, it makes it easier to implement those things.
I like that a lot. And Rylee, what's your insight from like the deep dive you did as well of what do you think there?
I think that in this study it was really cool because they utilized people who already knew how to use the technology. So the patient didn't have to do any thinking behind it. They're just like already set up, ready to go whenever they're ready to accept that help. So using like the tablets to connect them to physicians right there or in the mobile units, like bridge that gap. And it's also nice using digital care for those like that don't necessarily know how to use it, to have a place to go where they don't need to know how to use the technology, but they can still get the care that they need. So I think that telehealth and tech-based care in general can either widen disparities or close them. So it all depends on how we're intentionally like designing them and how we fund them and implement them into practice.
Yeah, I think what's fascinating here to me also is gosh, I like that you brought up the word funding. Like, what are we putting money towards? And Quincy, your thoughts on like, does this enable like a new wave of how rural healthcare is done as well? I love these ideas. I think it's brilliant, and there's got to be some sort of grant opportunity for care in rural health of how that's done. And maybe this also would be a like physician and pharmacist satisfier to be able to meet with your patients in more of a controlled environment too. Like maybe there could be a telepharmacy access hub type thing of, getting that telepharmacy service counseling experience in a very like private place. Like maybe there's not a pharmacy next to you. Like I know some places in Utah, especially like Pinkwich and Helper, Utah, and Roy, like there's a lot of areas that if they have a pharmacy, it's not necessarily close. Or they might be, or Garfield, Utah, right, had a pharmacy close. And so then there's nothing out there anymore. And so how can we account for what is the pharmacy health access in those types of places? Man, it's kind of wild to think about. And how do you even upskill patients enough so that they could use the resource? To your point, like this study, very educated, supported, assisted patients, but that's not necessarily the resourcing that always exists.
Yeah, for sure. And then I'll just do one more question for you. How do informatics pharmacists help design workflows, or how could you help design workflows that support low barrier or harm reduction approaches, especially for high-risk populations like people who inject drugs?
That's a really good question. I'm like mulling it over because I think there's almost too many ways they could help.
I'm also mulling it over. That is a fantastic question.
Well, I mean, so a big piece of what pharmacy informaticists do would be setting up the telehealth systems, the questions that are there, kind of what's the clinician experience piece. Like, so if it is an easy to use system to give care to patients, you're going to have a higher uptake from your clinicians to want to give care that way. And so I think there's a lot of user experience pieces to it that we absolutely can have pharmacy informaticists help with. And similarly, what's the patient experience? If it's hard to use, we're going to have a low adoption. And so looking at how can we make it more intuitive of how to use the platform, have really clear like action steps of what's next, what button do I push, not having too many options. So that way it feels really clear. What does the intake process look like? Probably is a big deal from a patient experience standpoint. So informaticists being very in tune with how much information is too much to ask up front that might kind of scare patients away from completing the process, I think is a big deal. Sometimes we get really into the data and may ask for too much before the visit versus what can you collect in the visit. Again, if it's in the visit, what might be nice is then you have a clinician kind of walking the patient through what information you're actually asking for. Because I think that's a question I always have of whenever we ask patients about their medication list, they're probably forgetting their monthly medications or medications that have been discontinued months ago that might still matter, like amiodarone hangs out in your body for quite a bit. So to me, having a more personalized experience versus just a medication survey feels important because we just might have a variance or degrees of patient understanding. And I think those are very real insights that a pharmacist informaticist can bring of like, okay, how much is too much data point collection? Like we want to collect all the data, but how much is too much? Because we're thinking about the experience also. I think a challenge, especially for persons who inject drugs or have an opioid use disorder, is they're already in this fragmented care environment and they have a lot of undocumented interactions, probably with healthcare, maybe under assumed names. They might have low trust in formal systems. So I think whenever we think about what the data we're collecting is, recognizing that this group may be a little hesitant to be truthful, I think the connection between healthcare and like, what's the word? Like the legal system may not feel separate to people. And so they may not necessarily want to create a record under their actual name. And so how could we help them feel safe or ask, is this an assumed name or is this an alias? So that way, and what aliases have you used in the past? Is it possible for us to gather information that you may have come into the health system with previously? I mean, there's so many pieces of the data puzzle too that I think pharmacist informaticists could be really helpful in identifying that may not necessarily feel instantly obvious. But Quincy, what's coming to mind for you? Because this is a hard question, Rylee. Thank you for asking us. Very broad. Like this is the stuff. I like this question.
So I think something that I think of too, and it kind of has to do with patient experience, but I think a huge component of helping patients have better experiences, and I think a lot of times to have better outcomes is just for them to feel empowered in their health, to feel like they can make a difference in their own health, like decisions that they're making, and just that they have like a little bit of control or a little bit of say, I feel like can be really impactful. So I think with it being more of a telehealth thing, you would want to still be able to have that, not even necessarily like, well, yeah, like a relationship with the patient, but also just a good opportunity for them to feel like they are empowered and they're understanding what's going on. They know what they need to do. And like Megan said, I think to not make it overcomplicated, but just a huge emphasis on them kind of knowing what do I need to do and helping them understand. Because I think in doing that, you could really empower a lot of people and make a lot of big changes for them. I didn't think about what you said, Megan, but just that importance of the aliases and trying to keep all of that safe for patients too, because I do think that is something that could be hard via telehealth, even harder via telehealth is to keep all of that straight. So I think that's really important. But I think mainly, I think a huge portion of it would be just that patient interface. What's their experience like? And I think it would be really important for them to feel like they had control over what was going on and that they were making their own decisions and informed decisions, maybe despite being super far away from a pharmacy and despite not getting to have that direct communication in person. And I think that that could make a really big difference for those patients.
Yeah, I agree. And that kind of leads me to something like a thought that I had. Just that it was really cool about this study is like they had those safe spaces that people were already willing to go to, and like it was a sense of community in a way. So if we could develop tools like they use, like the automatic lockers that they could store their medication in if they were unhoused, like it was a safe place for them to keep that in their pill locker. And then they can like, or have it delivered to them wherever they are living. So making like meeting patients where they are and having the tools like to help them if they don't have access to go pick it up themselves, but they can make it to this other facility or to the mobile site when it comes through, like having that access still, and being able to get it regardless and not have to worry about insurance and prior authorizations, and like having that safety net system and having that support system to help them, I thought was really cool. And implementing informatics like technology with tools like that. So
Oh, that's such a beautiful idea. I love that. Like some sort of, even maybe a little bit of like a temperature controlled area. So that way pills aren't in, I mean, Utah, right? Over 100 degrees sometimes here in the summer, or there's moisture risks. We get, I mean, torrential downpours sometimes where it's like, are we in Florida? What's going on here? You know, like Utah's got some funny weather. And those conditions aren't conducive to, especially buprenorphine, right? Like that's like dissolvable style medication is at risk to all sorts of like photosensitivity, it's a hydrophobic type situation too. Like you don't want to just pour water on that stuff. So this is fascinating. I love this idea, and I think it's a beautiful spin on it. I also think this population may have different job hours too. Like if they're able to work a little bit, it might be night shift or sometime where usually a lot of people go do errands on their lunch break. But if you're working a night shift, you might not have necessarily the access to do that. And then the time you would have to do that would be like, no, you're sleeping during when businesses are open. So there's probably kind of a natural gap there as well for a lot of folks that are trying their best. I mean, my goodness, trying their best, doing really hard work. How could we, like you said, meet patients where they are? And so some sort of pickup locker, even for new medications where it's more on their terms of when they can pick it up. That just sounds like a beautiful thing and helps support maybe a really challenging work and schedule environment a lot of people are navigating during those times. And that could be incredibly essential for getting people back up on their feet. I love that. And even access to, like if you have that little telepharmacy hub, like even have access to like bathrooms or being able to wash your hand, like, you know, like you're in a healthcare facility, like just having some conveniences too, so you can like water, like so you can feel your best when you're in a visit. I think that's a big deal too, of how do you navigate being okay enough to get healthcare. At some point you have to be in a certain mindset. You have to be critically thinking through, like, how do I talk through my situation? And it can be incredibly hard. So I that's a beautiful thing. I love what we both were talking about.
all right. Any other questions or anything you guys have for me?
Ooh, I had one. I'll pop in here. So I did think that this study was interesting because there was so much support for patients using the digital tools that were there, or like the telehealth tools that were there. I'm curious, if you were to design a study, would you do the same choices they did? Would you do anything differently, or would you add anything? Like, what would be your kind of dream design of a similar study, similar outcomes you're trying to get to, similar patient population? How would you design it?
Yeah. So I mean, ideally, I'd like to do a prospective, like controlled study design rather than like the retrospective review, including like comparison group for people that are receiving like the standard treatment, like office-based with a provider, and then like those that have the telehealth support access. And then I didn't love how the inclusion and exclusion criteria weren't super clearly defined, so I'd make sure that that's very clear. And using more structured fields within an EHR system to keep the data more consistent from patient to patient. And then, like you kind of talked about earlier, ensuring that we're using like standardized forms, like for everyone, to also kind of eliminate like the variability. And then I would do like longer outcomes rather than just 3 months. That seems too short. So maybe like including 6 months or 12 months or however long. And then I would also try and do it between multiple sites to diversify the patient populations, where this study was just done in a single site. So it was kind of limited and very like controlled to just that population, where it is an academic institution. So just expanding it outside of that, I think, are things that I would do if I were to do it again in a larger scale.
I think that's a really thoughtful way to go about it, especially recognizing that long-term outcomes are a big deal for this patient population. Like, yes, the short term, but we also need to be thinking about 3 months is very short term. Yes, that's an important time stop. Sometimes it is like a month to month, a week to week situation, but trying to get an idea of what is really moving the what's the phrase? I forgot the phrase, but like moving the mark on trying to really support these patients getting into their health, supporting their health, and moving into a better situation. I mean, that's the goal, is to really support patients at this really incredibly hard time and this really dangerous time. I mean, these are really tough situations people are in from an injectable drugs standpoint. And so, you know, how do you really support them in a long-term strategy? Would be so fascinating to see. So I love that point.
I also love that you said the long-term thing, because I will say that was like my one thing. I was like, 3 months is really, it feels very quick. Like, I feel like you could easily have a patient that's coming in for 3 months, you know what I mean? And then kind of lose steam and lose motivation.
Yeah.
So I really liked that. I think one of my questions was, I know you said it was, and I might just have missed this, but I know you said it was just one location, but in regards to that one location, was it like, where were the patients located? I didn't see anything like in the exclusion criteria, but like, did they have to be within like a certain mile radius? Because I didn't know, like, with it being only one location, did that end up being okay because they were able to have patients from so many different places? I don't know if that makes sense.
Yeah, no, that makes sense. And they didn't really state anything like that specifically in the study. So I could try and find that information and see if they included a radius. It was very like basic information that they included. So I might have to dive deeper into it, but that you make a good point. But they also had like their mobile units that they were using that they were already like had with that facility. So I don't know how far they traveled, but they had that main like building location and then said mobile units. I'm not sure how many either, but so I'm not 100% sure on the radius, but that is a great point.
Yeah, because I think that's something, once again, that's so cool about the telehealth, is that you could reach people in a way bigger scope. So it would be really cool to see it at multiple sites. And I mean, that always feels better when you're doing a study, to have multiple sites and multiple, also, because it's not just like how many patients you're accessing, but it also is like, how would this work on average with different providers and different pharmacists and things, because it's so much can vary, unfortunately. But yeah, so I think that's something that's really cool about it being telehealth, is it could have reached far. I mean, you wonder if it did because it was at an academic site and everything, but yeah, I was just curious about that. But no, that sounds great.
No, I like the multi-site thing as well, because what if there's extra resources or less resources somehow around that site? So the study reproducibility could be limited elsewhere just by the confounders that may not be known of what are the circumstances of that area. I mean, Miami doesn't necessarily have snow that happens as a weather issue, or there's high humidity certainly, but there's maybe not as high as temperatures as other places in the US. So is that a factor in people's ability to get out and get care during certain hours of the day? I know in Utah, a lot of our unhoused population does seek shelter during the day and might sleep during that time. It might feel a little bit safer to sleep during the day. And during the time where if you are out and about, it might be a little bit more dangerous to your health from a dehydration standpoint to be out in the weather or traveling somewhere. And so I know I have seen that that's like a high sleep time, and then they might want to be more aware and awake at night because it might be a little bit more dangerous of a time, or they might have work during that time, or like it's just a different how reproducible is it truly with not really a lot of knowns around that particular area. But because we do know where it is, we could, always research and think about those things. We just don't know if they're impactful to the study or not because they weren't looked at. But that's a really great point. My last question for you, Rylee. So I think we were talking about this yesterday about where, since we're 5 years out from the initiation of COVID in the United States, we're still in that period of still understanding how has that impacted us as a society. Like, what would this study look like pre versus post COVID? It does seem like the data was collected post COVID and analyzed even further post COVID. But I just am curious, like, do you think people are more okay with digital health services, less okay? Do we feel like they would have been okay with telehealth during that time period of the study and maybe it looks different now? Or just any insights there, would love to hear.
Yeah. So I think before COVID, like telehealth was pretty uncommon. Not very many people utilized it. So COVID changed a lot of things, like as far as like approval for medications, like the COVID vaccine and everything like that. So telehealth really kind of blew up during COVID because nobody wanted to go out and see the doctor and risk going to the hospital and getting more sick than they already were. So I think the biggest things, like I said, is IRB approval and implementation of telehealth based protocols is huge. And now because of that, more patients are more familiar with the technology and the tools to see a provider through telehealth and access it that way. And because of that technology, we have a better chance of conducting a multi-site, hybrid model kind of study with it. And now, looking at it 5 years down the road, a lot of those emergency waivers and stuff are expiring, so we don't really know the future of telehealth and all of these protocols, like being able to prescribe buprenorphine via telehealth. So that could revert back, and you have to see a provider in person. So it's kind of unknown, but I think that technology is the future, and technology-enabled substance use disorder care could be a great tool and a resource for a lot of people. And I think this study kind of showed us a little glimpse of that if it's utilized the right way. But as far as long term, I think it'll depend on what we kind of talked about as far as policies and funding and being able to integrate resources like this into a more structured system like an EHR and redesign the systems to center the needs of those vulnerable populations.
Wow, that was incredibly well said, Rylee. I really like what you pointed out there, and I think that is a fascinating point about the expiring waivers for emergency type care that have happened. And now is the argument that this has become the standard of care, so it's something we can't take away, or does it revert back? I mean, that's something that it's hard to tell or hard to know. So it'll be interesting to see what type of advocacy helps shape those efforts, because it certainly seems like, especially with maybe the more tumultuous scheduling that and instability in this population, that a digital access point seems highly aligned with a population that has more flexibility needed. So what a great point. I love that. I hadn't been thinking about that. Any last questions from the group? I think wow, I love this discussion. This has gone really well, but want to make sure if anyone has any other thoughts.
No, I think that you did a fantastic job, Rylee. I really enjoyed that. And I really enjoyed the discussion after. I thought your questions were very thoughtful. Like, they really made me think. So I really enjoyed the questions and I enjoyed the discussion, but you did great.
Thank you.
I agree. Solid work. Absolutely felt that you had strong preparation overall. Thank you for deep diving and becoming an expert in this for us to learn more about this study and this space overall. Nice work. I'm going to